Well, thank you so much, Jennifer, for having me here today, and the entire team at the University of Ottawa. It's such an honor, and it's an absolute pleasure to be here also because I'm just excited to see Daniel Buchman speak, and that is why I'm here. But before we get to that, I'm excited to talk to you guys about palliative pain control in the shadow of the opioid epidemic. I've spent the last half decade spending a lot of time providing palliative care to people experiencing structural vulnerabilities in our communities, people who are experiencing homelessness, poverty, mental illness, and other structural vulnerabilities that put them at risk of worsened health, but also have limited access to healthcare to begin with, through the delivery of palliative care, an approach to care which emphasizes quality of life for people who are dealing with serious disease. We're talking about people who have serious diseases and illnesses, but also suffer from severe deficiencies related to the social determinants of health. My journey started in my residency program when I met Terry, and I always honor Terry everywhere I go, no matter what. There's always a slide about Terry because he was the first gentleman that I cared for. He was experiencing homelessness. He had severe mental illness. He was a person who used drugs and could not get access to palliative care or pain management for his disseminated, widespread head and neck cancer. He ended up overdosing on a combination of alcohol and street drugs as I tried to gain supports to support his care, which really led me down the journey that really leads me to why I'm here today. Today, I'm also reflecting on Pandora, a young woman who I cared for, who was in her 20s when I met her, but fell to a life of being on the street due to physical and sexual violence that she experienced as a child. She moved from Alberta to Toronto and fell into a life of drugs. She later was diagnosed with a complicated diagnosis called infective endocarditis, experienced heart failure, and due to stigma related to her actual drug use, was denied potentially life-saving surgery and was discharged to the street. I hold Terry and Pandora very close and near and dear to me. And I think it's very important to, if we're in these conversations, to center ourselves around the people that inspire us, the people that we care for. The program that I'm involved in is called the Peach Program. In 2014, we launched this mobile street and shelter-based palliative care program that aims to provide palliative care to people no matter where they are, on the street, in a shelter, under a bridge, so no person falls through the cracks. The program is located in Toronto, Ontario, and is a program of the Inner City Health Associates. By combining pain and symptom management, medical approaches, psychological and psychosocial approaches, while also navigating a complex health and social system, we've been able to take care of hundreds and hundreds of people. And the program has grown over the years. We do like to take fun, goofy pictures, all pre-pandemic, of course, but the team is a non-hierarchical flat team that includes peer workers, nursing care coordinators, health navigators, home care coordinators, PSWs, and other allied health staff, and 4 palliative care physicians. At any given time, we care for between 90 and 100 Peach clients in the city, and it's been a real privilege to be a part of this journey. As I thought about today's talk, I started to think about the obstacles we see in our healthcare systems. And no, this is not a talk on public spaces or public engineering, but I think this is a good analogy for the kinds of conversations that we're about to have. In Toronto, a couple years ago, there was a large hospital that placed spikes on a grate outside of their institution where people experiencing homelessness would obtain warmth. The institution, by the way, responded very appropriately, apologized, removed the spikes, and have since taken steps to improve care for this population. But it really begs the question of what we are doing and explicitly to structurally exclude populations from care, the care that they deserve. If we're putting spikes outside a hospital, or these railings in a park that say you're not welcome here, what are we doing implicitly in our healthcare systems? And I think that's an important concept that we'll be discussing today. To really drive home the message, I wanted to talk about 10 challenges in palliative care pain management amidst the opioid overdose crisis. So if we're all kind of geared up for that, I'll just jump right in. Number 1, harm reduction in the palliative care community. For those who are new to harm reduction is a strategy that is used in multiple areas of healthcare that seeks to minimize the harms associated with drug use and drug policy without requiring the individual to have a goal of abstinence. For example, we have seen in our communities such incredible efforts, and actually some of the people I really admire who are amazing advocates in this province and country are on this call. So I'm kind of nervous to see their names here, but kudos to all of you for all your work, because you're a huge reason that harm reduction uptake has been accepted in many places in the country. I know we have a long way to go, and we'll talk about that. In palliative care pain management, by and large, harm reduction has not been adopted in pain management for people with serious diseases. I say this as I'm a palliative care doctor first, having gone through training, being in the academics and on faculty at 2 universities. We lack training in harm reduction approaches to support people when dealing with palliative care pain. Number 2, stigma, and I know Daniel will be speaking about this, and I don't want to get into it too much, but when I think about the stigma that people who use drugs experience amidst the opioid epidemic in our healthcare systems, it brings me to tears. And you start to think about stories like Pandora, someone who I carry with me all the time, and start to think about her situation she was in, and many people that I work with really feel that she was discriminated against and did not get the kind of surgery or medical care that she needed. In fact, there has been research to show that the kind of surgery that she needed is not dependent on whether someone uses drugs or not, but our experience with her and other people like her is that this happens all the time. It goes without saying that COVID-19 has changed things for a lot of us. Well, they've really changed things around pain management in the palliative care setting in our streets as well. Due to the pandemic and due to a tainted drug supply, we are seeing an increased presence of carfentanil and benzodiazepines in fentanyl. An analysis recently completed showed that business closures, border closures, and other factors are affecting the illegal drug supply in Canada in several ways, decreasing or changing the availability of different drugs, increasing prices of drugs at the same price, but more diluted, and increasing alteration of these drugs with associated health consequences. Obviously, this is having a huge impact. There was a time early on in my practice where, even if there wasn't a harm reduction facility or practice nearby, I would say to a client, hey, it's okay. If you want to use drugs, we'll still work with you. And I would say that saying, I was being progressive and I'm being very person-centered. I now say that and realize that that might actually do harm to the person I'm speaking to, which brings me to my next point. With that said, it's more important than ever to think about scaling up harm reduction and safe supply policies in our country. This posting here on the side is one recent federal announcement, which I welcome and support, but is one small announcement among a sea of issues that we see across this country. The criminalization of drugs and drug use forces people to turn to underground markets where the strength and toxicity of substances are unknown and the risk of experiencing harms is higher. Safe supply programs expand harm reduction beyond consumption and treatment services. They include distributing substances to users as alternatives to street level drugs that may be contaminated with other additives. I think we really need to think about what inaction on these policies has done to people. People are dying. More on that in a second. Number 5, we have to recognize that our healthcare systems are colonized, and to achieve success, we must keep calm and decolonize. Indigenous harm reduction, it has the potential to reduce the harms of colonialism. In Canada, Indigenous people experience higher rates of injection drug use and less access to healthcare than non-Indigenous people. For many Indigenous people, drug use can offer a mean of coping with trauma, intergenerational trauma, child welfare systems, legacies of colonialism and racism. And I speak to you as a privileged person who does not, could never really understand the experience of an Indigenous person on the streets, of an Indigenous person who is dealing with a substance use disorder, or an Indigenous person who experiences pain. What I hear and what I've learned from experts in this field is that we need to decolonize our healthcare systems. Number 6, racism has to be viewed, not race, but racism has to be viewed as a determinant of health outcomes. We have seen, and this was a tweet that I posted yesterday, we have seen as this pandemic has gone on that particular individuals, particularly people who are low income and racialized, are bearing the brunt of this pandemic. It goes without saying, in a city like Toronto, 2/3 of people experiencing homelessness are Black, Indigenous people of color. Meanwhile, we have a one-size-fits-all approach, often in most cases, to housing, to substance use, and to our harm reduction services. Racism is playing a big role. It also goes without saying that we need to think about racial bias in pain management. I have a thread that, if we have some time, I can get into later on Instagram, that goes through various facts that shows that people who are Black or people of color are much less likely to receive pain medicine if they go to the emergency department. Women with metastatic cervical cancer who are people of color are 3 times less likely to receive opioids. And that research from medical education in the United States and other areas shows that white medical students and residents graduate thinking Black people have thicker skin, so that they actually are prescribed less pain medicines. This is actually true from the literature. Number 7, siloed models of care. And if I could give a shout out to one document that I think is worthwhile to read, it's Too Little Too Late: How We Fail Vulnerable Canadians as They Die and What to Do About It. I was a co-researcher and author on this paper. It was a public paper that then became a research paper that followed 25 marginally housed people for 2 years through ethnographic research. And we just looked at their experiences. We found a lot of things, but the one that's relevant to this slide is the idea that care is siloed. You have to go here for your housing, here for your medical care, there for your income, there for your primary care, there for your oncology care, and then here for harm reduction. Integration is lacking. And for people in pain on the streets, for people who are experiencing pain, this is very challenging. Number 8, home care needs to meet people where they're at. One of the findings from the Too Little Too Late study, and something that I've experienced and continue to experience all the time, is that home and community care is really essential to supporting people who use drugs, people who are in pain, and people who experience homelessness. Yet integration is lacking and inconsistent across the country. What we found in the Victoria, British Columbia study, Too Little Too Late, and in our own findings, is that a home and community care agency, by the way, for profit or not for profit, can, on the flip of a coin, can just say, you know, we don't feel comfortable going in that building. Oh, there is some drug paraphernalia on the table. I don't feel that that's safe. Or an entire building is off limits, or they actually say that entire neighborhood is a no-go zone. These, to me, are examples of structural exclusion by way of postal code and income. And to me, I don't understand. I'm not a law expert, and I know there's a lot of law experts in the audience. I don't know how a home care agency or a health region can allow that or allow that to happen. This is what we're seeing on the streets, and I'd love to hear more from everybody who's in the audience. Number 9, we need to think about the frontline workers who are working with this community. They are grieving, they are bereaved, they are seeing death and dying every single day. In Ontario, our coroner is reporting deaths of upwards of 55 deaths per week. In Ontario alone, this is a report from nearly a month ago, 900 deaths, overdose, opioid deaths in this province. That's not taking into account what we're seeing in BC and Alberta. People are burning out. They are experiencing moral injury. They are experiencing compassion fatigue. In our little corner of the world, we've started these healing circles as a way to support inner city workers who support people experiencing homelessness, in pain, who are dealing with physical and emotional pain when they die. And what we find is there's a huge turnover rate among staff working in this sector. And what we do is, when someone dies, we go to the shelter, we go to the facility, and we have a ceremony, we light a flame, we hold a moment of silence, and we grieve, we cry, we laugh, we support each other, we remember the person, we reflect on the person, and we think about ways to renew and reinvest in each other. It's just scratching the surface, but it's an active way that we're trying to address and support a bereaved frontline community. And finally, number 10, something that just irks me every single day, is we are creating policy around supporting people who use drugs, people experiencing homelessness, and people experiencing pain amidst the opioid epidemic, and we are not including their expertise as part of that. And so when we're really thinking about going from equality, where people get the same things to be happy and healthy, to going to equity, where people get what they need to be happy and healthy, we need to go to justice. And we have a justice-based healthcare system when we include the experience and expertise of people, the very people we're talking about in this session today. I think one of the things that I always carry with me is this. It's an avocado. And my colleague, Dr. Sandy Buchman, one of our peach physicians, taught me about this a long time ago, and I'll never forget it. He asked me, what is your social accountability to the system? What is your contract with society? And I know that many of us work at different levels. Some of us work at the micro level, some of us work at a meso, and some of us work at a macro level to inspire change. Some of us work at one level and some of us work at different levels, and that's totally okay. And I wanted people to think of that as we move through this session. And finally, I did want to end with my favorite street graffiti art of all time by Banksy. We can think about the change we want to inspire, you know, superficial, band-aid, charity oriented, and that's fine and dandy, and I'm not knocking charity, I think that's important. Or are we going to dig at the roots to really think about the structural changes and deconstruct structures of power to support people who experience structural vulnerabilities? And with that, I will hand it over to Daniel. Thank you.
And we'll have some questions and answers at the end, but over to you, Daniel.
Is it showing up? Everything okay? Great. Well, hi, everyone. Thank you so much to Professor Chandler for inviting me here today. It's a real honor to be speaking on this panel, and especially to be alongside Dr. Dosani. I don't know how anyone can ever follow Naheed. That was such a wonderful, wonderful presentation, which with many 10 and more critical messages that we need to consider. So I'm going to talk today about ethics of pain management in the shadow of the overdose crisis. I received funding from CIHR on research related to ethics in chronic pain, substance use, and then separate grants on substance use, palliative care, and COVID-19. I have some funding related to hospital-based harm reduction, and I'm a co-investigator on some Health Canada grants looking at the overdose crisis. And I have no other financial conflicts of interest to declare. So I want to start the talk today by centering it on a concept that physician Mark Tyndall and harm reduction activist Zoe Dodd in a recent article called response paralysis. And response paralysis is a term that they use to describe how governments, how their failure to act decisively on the overdose crisis itself can really only be explained by the embedded and entrenched stigma, prejudice, and discrimination that is directed toward people who use drugs. And when we think about pain management and the overdose crisis, we're talking about two concurrent crises of historic proportions. There are obvious overlaps, and I will talk a bit about that today, but these are also two concurrent crises that we've been experiencing for a number of years. And actually, I wouldn't say it's one overdose crisis. If you actually look at some of the data from across North America, there's multiple sort of regional or statewide or provincial overdose crises, and many communities, particularly structurally vulnerable communities, and those who Naheed was discussing earlier, have been experiencing overdose crises for a very, very, very long time. Much longer before it came to the public attention with respect to substances like OxyContin. You know, 1 in 5 people live with chronic pain in Canada, and there's increasing rates of suicide, depression, mental health concerns, and this costs billions of dollars a year. In Canada, there's been over close to 17,000 apparent opioid-related deaths between January 2016 and March 2020. That is an astronomical number. Each one of these is a life lost, a preventable death, is a tragic, is a person with family, friends, network. There were, in Canada, there was over 20,500 opioid-related poisonings requiring hospitalizations during this time. So these are not necessarily deaths, but these are people requiring hospitalizations. And again, these are numbers that exclude Quebec. These are just astronomical numbers, especially when you align them against other concerns such as people who die from cancer, HIV, AIDS, and even in context of deaths from COVID-19. Since COVID started, actually the record for overdose deaths just, I hate to use the term, breaks the record every single month. In September in Toronto, for example, there were 19 suspected overdose deaths. So this is just a huge crisis. This briefly just is some data from Alberta on the left of your screen, Alberta and BC on the left of your screen. You can see both where we're at from 2016 to 2020 in terms of fentanyl and non-fentanyl related deaths. You look at Q2 of 2020, the rate has absolutely increased. We know that COVID has intensified structural vulnerabilities in society, and people who use drugs and people who are vulnerable to overdose have been particularly vulnerable here with increasing rates. And similarly, if you look on the right, these are illicit drug toxicity deaths from British Columbia that was recently released. So from January 2010 to August 31st, 2020, you can see how the rate of overdose deaths due to the illicit drug supply has, again, skyrocketed as well, and we're not even done through 2020. So one issue that I will argue is central to all of this discussion, and as I situated in context of Tyndall and Dodd's response paralysis concept, is stigma. Stigma, as my colleague Daniel Goldberg has described, is difference plus deviance. So a powerful in-group must mark a less powerful out-group as different based on a shared characteristic, typically a demographic characteristic. And then this difference is then assigned what's called a normative label of deviance. And so we can see in this way, and by some of the data I've just shared and what we've heard in Dr. Dosani's talk, is that stigma is bad for your health. So members of social groups who are consistently subjected to stigma get sicker, and they die much earlier than those who are not subjected to such intersecting powers of densely woven patterns of disadvantage and densely woven powers of stigma. And so in this way, we can see how stigma tracks social inequalities. I think it's well established and well known to the audience of this panel here today that both chronic pain and substance use are highly stigmatized. And when both occur concurrently, the stigma is intensified. So for example, people who live with chronic pain are often considered lazy. They're complainers or they're faking it. It is quote unquote all in their head. It's not real. And also that they're untrustworthy. People who use drugs are often stigmatized as making bad or poor choices, not caring about themselves or others, not having any personal control, or are diseased, and they're often targeted of associated stigmas such as criminality and those associated with poverty. These are all worsened by a relentless and harmful, damaging war on drugs. Opioid manufacturers such as Purdue Pharma, in their sort of well-documented aggressive marketing tactics of their long-acting opioid OxyContin in the 1990s and 2000s, made the misleading claim that the likelihood of addiction from taking OxyContin is less than 1%. This was demonstrated to be a false claim that was central to its advertising because they knew people, and physicians and prescribers in particular, have an intense fear of addiction, and physicians would not prescribe the new drug, which physicians did in droves. Now, I'm not going to spend too much time on the Purdue and other opioid manufacturers' story in terms of the opioid prescribing, because I think we could have a whole seminar on that in and of itself. But just to sort of highlight how central this initial piece was to the contemporary crisis that we're thinking about now. So if we fast forward to 2016, some new evidence was emerging about the harms of prescribed opioids. And this has started, I think, coming around 2011, 2012. And this is not just on substance use disorder, but other indicators of morbidity, opioid-related morbidity and mortality as well. And so the CDC and the Center for Disease Control in the United States issued guidelines, and actually Canadian guidelines came about a year later, which was discussing restricting opioid prescribing in order to mitigate the increasing harms we were seeing from prescribed opioids in the population. And I'll just say, rather, to Naheed's earlier point about race and racism, this was, again, in a largely white and middle-class population. But by and large, these guidelines were largely misinterpreted. And if you quickly sort of look to the charts I have here on from the JAMA paper, around 2012, 2013, there starts to be some trends in how opioids are being prescribed. And then around 2016 or so, when the guidelines came out, there was a rapid sort of increase in dose tapering among people who are consuming opioids in a pain management context. And these prescribing guidelines were devastating for people in pain. Many were abandoned or felt abandoned by their physicians or their prescribers. Many turned to street sources to find pain relief. And at the same time, there was an increasing toxic supply of fentanyl analogs and heroin, and many did overdose and continue to overdose, and many as well were driven to suicide. Just quickly to look at some of these graphs, this from a paper by Benedict Fisher and colleagues, you can look at around 2011, 2012, when some of the evidence started to emerge around prescribing opioids and some of the harms and sort of challenging some of those initial claims made by Purdue and others, that if you look at the black line, prescribing rates just go down. But if you look at these deaths and the blue line here, at least in the Ontario graph, sort of remain somewhat constant. I mean, still very high, but that deaths due to synthetic opioids or fentanyl just absolutely skyrocketed exponentially. So really, this is an illustrative point here to say what the impact of these changes in opioid dispensing. And I don't have much time here, but I would encourage everyone to listen to the phenomenal podcast Crackdown. And they have actually, their episode that came out on Monday talks about this very, very topic around what happened around, at least in BC, around some of the prescribing rates, and they just do some phenomenal investigative journalism. So many people who were living with chronic pain, who were benefiting from opioids, were really, really harmed by the outcomes of this policy. And there was considerable pushback in the media, and as because many people who were living with pain were suffering terribly. And so we saw, headlines like opioid overreaction, when the cure is worse than the disease. Good news, opioid prescribing fell, but the bad pain patients suffer, doctors say. And so what was happening is that people were as I mentioned, there was increasing rates of mental health concerns, suicide, people they were needing pain relief for their suffering, and accessing street sources which were coming from an illicit, toxic supply. But this discourse around opioid prescribing had the consequence of further reifying categories between the deserving patients and undeserving patients, and people who had legitimate claims to pain and illegitimate claims to pain. And this idea that I have here comes from a wonderful paper from Kirsten Bell and Amy Salmon from 2009, and they were talking about the concept, sort of the discredited concept of pseudo-addiction, where they argued that discourses on pain management that distinguish between the deserving pain patient and the undeserving, quote unquote, addict. Now, it's not a term I like to use because it's highly stigmatizing, but this is how the discourse ended up shaping out. And so what this served to do is further reinforce the distinction, or stigmatize people who were subject to this stigmatizing label as addicts, as delegitimizing the claims to pain that they might make. So first of all, it presupposes that people who use drugs do not have chronic pain, or that they do not have legitimate claims to pain. And when in fact, the prevalence of chronic pain amongst people who use drugs is in the literature upwards of 60%, where if you look at the prevalence of people in the general population, the prevalence is 20%. So it's not as if people who use drugs have huge amounts of chronic pain. And so this idea of legitimate versus illegitimate and contested identities were playing out in various sources. And we see in research that people who are living with pain were actively resisting the stigmatized identity of the quote unquote addict. Studies were finding that these dichotomies were reinforced for the public in spaces by images of people dying of opioid overdose in major urban centers, and other sort of dominant media representations of opioids as dangerous threats to communities. And so you can just see here sort of a sort of selection of headlines from the news and also from Twitter and elsewhere, where this distinction was made between patients, not addicts. That somehow there is a difference between people who need to access opioids for pain for quote unquote legitimate reasons and people who might be consuming drugs. And so you see, so if you put into Twitter the hashtag patients not addicts, you get tons of tweets and discussions that are sort of further reinforcing these distinctions. You know, you look at that Washington Post headline, you know, I'm not a junkie, give me the painkillers already. You know, we're not all drug addicts, the plight of chronic pain patients during the opioid epidemic. And, you know, I want to just say that people, like, as I've mentioned, and I want to emphasize, people living with chronic pain are suffering tremendously and have been harmed greatly by policies related to the medications, which many, many people benefit from. But this is, again, a worrisome trend within an already stigmatized community, further stigmatizing an already stigmatized group within it. And so when this further disadvantages an already disadvantaged population, I mean, this is problematic ethically for many reasons, but also, you know, furthers to entrench in the inequities and that many that Naheed spoke of earlier. My colleagues, Dr. Fiona Webster and Dr. Aviman Yusud and others did a really interesting critical content analysis of media reporting on opioids, because media does have, as we all know, and as we've seen in the context of the pandemic, a really important role in shaping how various publics and their perceptions about health. So they did this content analysis of Canadian newspaper media and opioids, and they found, amongst many things, similar to what I've been talking about, a characterization between people who are just sort of, you know, so-called deserving of treatment. So these are people with quote unquote, you know, genuine chronic pain, and people who are considered undeserving. So these are people with stigmatized identities of addiction, which is also associated with being poor, with poverty, with being street involved, with people who use drugs. You know, so these quotes that I've pulled out from their study, you know, the emphasis here is mine, but it just shows to show you, you know, people say, you know, Leonard Briere is no junkie, yeah, but he can't get the drugs that he needs. You know, painkiller crackdown hurts, you know, genuine sufferers. And you know, this person, Jim Burke, says, you know, I feel like I'm getting lumped into the same category as drug addicts, right? So again, more of this distinction between deserving and undeserving, and who has legitimate pain and who doesn't. So again, along class lines as well. This is a paper that came out about a year ago from our group, and what we did is we performed a scoping review of a literature to try to develop a typology of opioid-related stigma. And so what we did is we identified the type and the agent and the recipient of stigma as based, as well as the methodology and the substances that we were considered. Anyway, we found four themes, stigma being one of them, and I'm not going to spend too much time on it here, but basically we found that we wanted to look at sort of the different nuances or the different ways in which stigma operates. And so first of all, because it might look different depending on how the stigma is being constructed or by who is consuming the drug. So, you know, first and foremost, interpersonal and structural stigma experience toward people who are accessing opioid agonist therapy, such as buprenorphine or buprenorphine naloxone. That was one theme. A second theme that we found was the stigma related to opioids for the treatment of chronic pain specifically. Third, we found that there's a considerable amount of opioid-related stigma in healthcare settings. And four, that many people who use drugs and people who consume opioids have a lot of internalized self-stigma as well. And this may relate to issues around not being, you know, abstinent, or abstinent is an ideal that people need to achieve, or that if you're taking an opioid agonist therapy, such as buprenorphine, that you're not abstinent. And so you may not necessarily even be accepted within certain community or circles amongst people who are using drugs. So, you know, we argued that how opioid stigma is actually produced and reproduced really depends on the context of opioid use, the social identity of the networks of the person who is consuming the opioid, what opioid is being consumed. This includes medically sanctioned forms of treatment. And that, you know, we ultimately argue that limited clarity on the various nuances of opioid-related stigma has both practice and policy implications. Just in terms of understanding the sources of opioid stigma, how it does end up manifesting in various contexts, its impacted on affected groups and communities, as well as effective strategies in order to redress it at individual and societal levels. This article came out in the LA Times in April of 2019, and I often will, since that time actually, will include it in many of my talks on this topic. This was done by Ryan Hampton, who's someone who identifies as a person in recovery, and Kate Nicholson, a lawyer and legal scholar who is someone who lives with persistent pain. One particular quote of this article I find actually helpful to end my talk here on is that, blame helps no one. We have so much in common. Our stories are two sides of the same pill. Serious pain and addiction are public health conditions that are widespread, stigmatized, and misunderstood. So I will end there for now. Thank you all so much.
Thank you so much, Daniel, very much for your talk, and also thanks again, Naheed, for yours. And I just want to remind participants that if you will click on the Q&A button, you can send your questions into me, the moderator, to read out for the for the speakers. So please go ahead and send those along. And the first question that we have is directed to Naheed, and it is, what, if any, newly enacted policies have had unintended consequences for the population that you care for that have contributed to this spike in opioid deaths? So it's looking at the what sorts of unintended consequences recently of policy change have potentially explained this opioid death spike.
Yeah, I mean, I think, Daniel really well covered, some recent history. So it's worth reviewing it. The peak years, 1 in 5 Canadians were, receiving opioids for medical reasons. And all of a sudden that kind of goes out the window, and that changes. And so you see descheduling of select opioids, restrictive prescription guidelines, intensified prescription monitoring, and this creates the scenario where people are turning to the street. And I mean, that's recent history. This is not like it happened like 20, 30 years ago. It's pretty recent, and it's affecting people. But it's also, lack of holistic addiction services here in Ontario, such a focus on, methadone clinics, for example, which are really about going and getting an assessment and a urine sample. And I understand it's important, but what about the holistic approaches around spiritual, psychosocial biofeedback and holistic addiction services that are lacking, and lack of harm reduction policies? There's also evidence that there was a tainted drug supply that was increasing before the pandemic, and then the pandemic kind of totally escalated that. And there's all, border closures, international, economic relations with different countries, and, the China supply chain. There's all sorts of factors. But, my one plug for this question, I know I'm curious to see what Daniel thinks about this too, is the tainted drug supply is often what I see sometimes. That's what people point to. Oh, it's a tainted drug supply, or the media will just say that's what's causing this. That's a factor for sure. But this is an issue that we can act on. We can actually save lives. We have coordinated a intense public health response to COVID-19, and in the amount of people who are dying from drug overdoses parallels that. In some places is more than that of COVID-19, and we have not seen the coordinated public health response in the same way. So we can make a difference. It's not just a tainted drug supply.
Yeah, I mean, I agree with everything that he's saying. Tainted drug supply is one critical factor for sure, but not the only. I think it's the larger structural determinants of health. It's the how stigma and discrimination are baked into unjust policies and laws. Our drug laws in Canada and the US are inherently racist laws, and they have a racist history going back to the Opium Act, for example, in 1908. The US as well. This is consequence of the drug war. Or the drug war on people. I would actually, it's better characterized as opposed to, it's not a war on any drug, it's a war on people. So yeah, I mean, that's sort of what I would add to that. You know, I mean, I support, as Naheed does, you know, the increase in safer supply programs. I think that's one critical part. You know, overdose prevention sites, et cetera. But those that won't, you know, solve this. These you know, technological solutions won't solve social problems. You know, we need, this is at the macro level in terms of law and policy, really changing those and redressing those structural determinants of health.
A couple of participants are asking any ideas on reducing, addressing stigma. Daniel, you identified 4 kinds. Naheed, you spoke also about stigma against this population. And essentially, you both spoken about 2 stigmas, chronic pain as well as drug use.
Daniel, do you want to go first?
Sure. So stigma is a very complex phenomenon. And I think the stigmas that people experience, whether due to pain or to substance use, you know, it's not just the substance use stigma. It's often, you know, like as I mentioned, so stigma tracks social inequalities. So if you're stigmatized in one aspect of your life, you're going to be stigmatized likely in multiple domains of your life as well, whether that's sort of associated with poverty or racism, classism, you know, stigma related to discrimination related to gender. So it's, you know, there's often multiple intersecting stigmas along various axes of inequality happening here. But I think the question of how do we reduce stigma is an important one. Again, we'll say that, you know, our efforts to reduce, so first of all, the evidence about reducing stigma in substance use is mixed. There's some good evidence of short-term contact-based approaches. So that what that means is, you know, like for instance, like pairing like healthcare professionals or others in positions of power with you know, affected communities and working together. So completely like, you know, supporting what Naheed and many others have advocated for, and I advocate for this as well, is, you know, centering the voices of people who use drugs or people who are living with persistent pain, you know, in policy decisions. I mean, that I think, I mean, it's a whole, what that means can be a whole other webinar of what that looks like, because there's been a lot of very important critical scholarship on this. But that's, I mean, that's one part, but I think it's really, you know, it's a culture change. And, you know, in healthcare, there's so much stigma towards people who use drugs and people have pain in healthcare. And this is largely due to ideas in our Western, you know, culture about the importance of certain neoliberal values around independence and self-control and you know, being a good, you know, virtuous person, and all of these ideas, you know, that I think, you know, you know, changing hearts and minds, and this won't be done, and actually I would argue won't be done at a micro level. It won't be done through implicit bias training, because we all have our biases, and, you know, I think it's important that we're reflective and we think about it, but it's really these structural factors in the way we go about doing things, for example, in hospitals, around how we care for people who live with pain, how we care for people who use drugs, will go a long way, I think, in terms of redressing some of those stigmas. But I think more research needs to be done in that area specifically to look at how we can get better outcomes.
Like, I think I love how Daniel answered the question, because that is the answer. You need to look at the structural issues at play to answer that question. And let's be real, stigma won't stop until we start to value these people, we value their lives. We don't care about their lives. Our policies show we don't care about these people. They are dying amidst our presence and in our presence, right under our noses, and our policies do not reflect improvements around that. On a more optimistic note, I say clinically, I do, you know, just to switch gears, there is this concept of trauma-informed care. And it's unfortunate, you know, that it's somewhat of a buzzword to most healthcare professionals nowadays, but it's starting to become something that people are really actualizing and clinically, you know, doing. And for those who are new to the concept of trauma-informed care, it's a set of approaches, policies, and behaviors that recognize that much of what drives people's experiences and behaviors in our communities, particularly the populations we're talking about, is trauma. And so it talks about how we speak about the people people we care for. It's you know, calling them by their preferred pronoun. They're asking them what their name is, speaking at eye level. It's thinking about how we can be trauma informed before we meet them in a clinical encounter, how we are with them in an encounter, how we physically examine them, and how we refer them off to other services, for example. That's how we document and chart about them. There, you know, when I do trauma-informed care training for health workers, I have this like slide where I say things not to say, and it's funny, like it's not that black and white. It's more of a dynamic thinking, but I find that actually is successful in just saying, don't say this. Like, it's probably just better to not to say this. And then think different approaches. Like, he's not an addict. He's a person who uses drugs. We're even trying to stop saying a homeless person or homeless people. We're trying to say people experiencing homelessness. It's jargony and I get it, but this is trauma informed. But it even begs bigger questions around trauma informed approaches programmatically. I hope people would agree the PEACH program is a trauma informed approach to palliative care for people experiencing homelessness. And then at the macro level, safe supply, harm reduction policy. These are trauma-informed policies as well. So hopefully we can take that micro, meso, macro approach to social accountability and apply it to the concept of trauma-informed care as well.
And as you were both speaking, this is your area and you're the experts in it, and I'm kind of following along behind here, but I was linking this to an area in which I work in organ and tissue donation. It has struck me the complexity of the web in which this all sits, because we know, and we've had recent sort of discussion in policy around allocation for transplant or waitlisting of people who have either alcohol or substance use challenges, and can be sometimes a contraindication. And yet we also know that people dying of opiate overdoses are donating organs. And so it's a similar population who may be donating but not being able to participate in receiving the transplant. But there's also a COVID dimension to this too, because during first and now second wave, there's, you know, a lot of concern about creating people with after transplant who are immune compromised and at risk, and therefore thrown into the mix of who gets allocated is, are people able to self-isolate? And we come back to people experiencing homelessness, people who may be using drugs, who again on that count will probably be out of the picture or deprioritized for the transplant because they'll be at greater risk if they go for the treatment. So it's this web in which all of these things fit together to create sort of disadvantage on all kinds of levels. So I'm taking us away a bit from pain management, but I was noting that as you were speaking.
Yeah, I agree. I think, Jen, I think that's, you know, the let's say alcohol-related liver disease and transplant policy is a great example of, you know, stigma embedded within a policy. You know, you're actively excluding people who use alcohol based on zero empirical evidence. And it's a policy that's has been quite ubiquitous. Now this is changing a bit, you know, but that has greatly harmed people who use alcohol and had very sort of unrealistic expectations around abstinence. And what's expected for abstinence, and many people died as a result. Again, this, you know, the idea for, you know, someone has to be abstinent for 6 months was based on a consensus meeting at a 1997 liver conference. And that ended up being, you know, sort of extrapolated to other organ groups. So it's you know, I think that's a great, you know, example of, I mean, again, related to pain and substance use in very important ways. And also looking at populations who, you know, from an equity perspective, like who might be disproportionately affected by alcohol use disorder, or have concerns or percentage of alcohol-related liver disease, who are then not only sort of being, they're being systematically denied an access to a life-saving resource, and nowhere else in medicine or in healthcare does that happen.
Daniel, that was just like, I just preached, man. That was amazing. And that consensus statement has just been adopted in many centers across the country. And my understanding is around the world as well. And it's just structural discrimination, but it brings up other bioethical conundrums that we deal with through the PEACH program when we are seeing someone, for example, who's dealing with an advanced cancer. And, you know, we see this is documented in clinical notes, like, you know, an oncologist, for example, saying, I would have offered him chemotherapy, but he's homeless, so I won't because, you know, he doesn't have the conditions to receive the treatment. And you start to think like, wait, hold on, am I reading this in black and white? It's in black and white. And on one hand, there is truth, like there's post-care, and if you can't receive hydration, and, you know, someone can have a worse outcome, but we're structurally denying treatments, you know, so from transplant to chemotherapy to dialysis, like this is a very important topic to talk about when dealing with people, supporting people who experience structural vulnerabilities with serious illness. Absolutely.
Another question that's come in is whether you have some thoughts about how, at a time when we're utterly consumed by COVID, which is obviously a major risk to the population as well, how we maintain a discussion and focus some attention on these issues.
Yeah, so I mean, from a communications perspective, there's a lot of issues out there. I know there's a lot of people on this session who are, I know you guys are fighting hard in the community and you're trying to get your messages out in your area of work. I think dovetailing the way that the COVID-19 pandemic has specifically exacerbated these issues is a way to hook. And you know, whether it's social media or it's traditional media or it's just trying to get people's attention. And so if you're talking about the tainted drug supply, yeah, you can talk about a tainted drug supply, but talk about what COVID-19 has specifically done and how policy around that has changed things. You know, I've seen some incredible journalism. You know, Rachel Brown and Vice recently put out a piece that, you know, to me was just astounding, that she had to do so much work to get the death counts around opioid overdoses across the country. And she put it all together. It's, you know, supporting investigative journalism, and the journalists who are asking these questions. Andrew Wu at the Globe and Mail is another person who I deeply respect as well. So, you know, I think those are two kind of strategies, and there's a lot of like white noise, a lot of background noise going on right now to really get the messaging out there and at the forefront. Daniel, any other thoughts?
Daniel, I think you're muted.
Oh, no, I have nothing to add. No, that's, yeah, he said it all.
Okay, so I have another question for, I think probably for Naheed, but I may be wrong. And it's a question about how people are maybe classified as palliative because of medical stigma, like Pandora, who may be palliative because they didn't treat her endocarditis.
Yeah, so looking at the time, this could be like a 30-second rant or a 3-hour rant. I'll go with the 30-second rant. Palliative care, probably 10 to 20 years ago, was a very strict definition that focused around end-of-life care, you know, the last days of a person's life, for example. This has changed dramatically. You know, in 2020, palliative care is an approach to care which is emphasized for people at any stage of disease and should arguably be given to people right at diagnosis. People, the outcome evidence shows that people feel better and can even live longer. But that's often within a cancer paradigm. And what we've seen in the past is there is this kind of, the person goes through a disease journey, and then they're like curative, and then they're palliative, and then they die. And that's very old school. Nowadays, what we see is that as curative treatments, you know, sort of decrease, palliative treatments and approaches increase. And there's actually like an inflection point. And that might be a better way to think of things. In diseases like cancer, where you go through stages and it's more of a sort of a linear kind of diagnosis, that's an easier pathway to follow. But in other diagnoses like endocarditis, like HIV, which have different kinds of trajectories, this kind of palliative label can be very unfortunate and can be damning to the person, and can actually discriminate them in a way in healthcare that's not helpful. We're trying to go away from calling people palliative. It kind of like irks me when he's palliative, she's palliative. No, you know, he's not palliative. He or she is a person. They deserve care, right? And so what we're trying to say is that people benefit from a palliative approach to care. And you know, this question from Jillian is brilliant, because I have had cases referred to the PEACH program, for example, HIV or endocarditis, where they were dying. They didn't want to receive treatments. They were on the street, but then we wrapped around around pain and symptom management, medical care, emotional and psychological supports, and people got better. People went into remission. People's disease got stable. People even were cured, and we discharged them. And that's a great day at the PEACH program. And it should be a great day anywhere, you know, if someone gets better. And so I really appreciate the discussion about terminology and labels and jargon. I hope that kind of demystifies it a bit.
Yeah, thanks, Naheed. I think we have time for one more question, and I see a question that's come in asking how can a patient who is experiencing pain, how can they navigate against stigma? What is the approach a patient should do to both manage their pain and seek adequate care, and so forth?
That's a great question. I think, you know, it depends. I think that, you know, it may be helpful to speak with other chronic pain advocacy groups, other people who are going through persistent pain daily and interacting with the system on strategies that have worked well for people. It's a persistent problem. I mean, I think, you know, by and large, because, you know, we operate within a medical culture that prioritizes objective and quantifiable evidence over subjective testimony. And, you know, chronic pain is inherently subjective and an invisible condition, which is part of the reason why it's stigmatized so much. And so, you know, I think, and this is something I know I hear from colleagues and friends and people I've worked with that, you know, this is something that they come up against all the time in terms of their relationship with clinicians. You know, do they believe their testimony? And I mean, I don't have any specific, you know, strategies, because I think it really depends on the nature of the therapeutic relationship. And, you know, unfortunately, many people who are advantaged structurally, you do have a less, you know, still experience tons of stigma, but, you know, are less, or let's say privileged, even like due to gender, are, you know, experience less stigma, for instance, being a man with chronic low back pain than a person of color and a woman, or someone who identifies as gender non-binary or gender queer. Because even then, you know, you have people who are already considered untrustworthy, people who already met with skepticism, and then you have sort of these intersecting factors here that end up playing out in a pain management context that, or a culture of pain management that tends to prioritize this. Now, many, like, I'm sort of going off here, but I mean, even though pain management does by and large suggest that, you know, biopsychosocial approach to, or a multimodal approach to pain management is the best, and this is what people espouse. But I think in reality, at least from my understanding of people's experiences, it doesn't always happen that way. Although many people do experience some of those positives with their clinicians. Now, I have to say, what can someone do? I mean, I hate to say it, but like, you know, if you're lucky to be your own best advocate, to have support network around you that can fight for you and continue to fight for yourself. I know it's exhausting, and I wouldn't in any other cultural context recommend something like this, but this is sort of a very pragmatic suggestion and a reality until sort of these kinds of things can change.